mostly sees, very good. She mostly sees general adult populations struggle with depression, anxiety, bipolar, and other mental health problems. Dr. Hahn occasionally provides individual, group, family therapy as well. So she enjoys educating residents and planning and participating in substance abuse lectures in the spring. So when we have somebody who is needing some type of detox, we call on Dr. Hahn, and she gets them in and gets them detox very nicely and then hands them right back off to us. And so then we continue on with the outpatient work. So, Dr. Hahn, we're lucky to have you today to talk to us about inpatient treatment and detox. So I'll hand it over to you now.
Alrighty. Okay, let me try and share my screen now. Okay, it works. Is it working?
It is.
Oh,
We're
cool.
good.
Okay. So my talk is gonna be kind of presented in like a case format. So it'd be great if you guys can I'm gonna ask a lot of questions during my lecture. So if you can, chime in with your voice or even the chatting screen, that'd be super helpful. It's a very somewhat of an interactive session. So yeah, please jump in whenever you can. So today's topic is alcohol detox on the medical floor. Wasn't sure what would be the most helpful for you guys, but I kind of wanted to show you, looking to the learning objective, in the hospital setting anyways, like what are the different levels of alcohol use disorder, and kind of introducing the different levels of alcohol intoxication and then common alcohol withdrawal symptoms, and then also showing what it looks like once the patient is hospitalized in our unit, and then what resources we offer. I got our coworker Ashton, who is our case manager in our unit, and she figured these would be some things that might be helpful or interesting to you guys anyways. Ready? Let's see. So we're going to start with a case presentation, basically. So I'll read this and then you guys can answer. So a 55-year-old Caucasian male called the intake coordinator saying that he wants a detox from alcohol. So he's been drinking about 10 years ago, and in the past year has been drinking about a fifth of the whiskey every day. He has been able to remain abstinent for 3 to 4 months, then relapsed about a month ago. He's been falling often since last July and fell again yesterday and hit his head on the dresser. Wife was very angry about this, and they had an argument because they said they promised he would not drink anymore. He's been going to work, but has been missing work during withdrawals or injuries sustained due to drinking. So this is actually based on a real case, and I kind of tweak things later, but just based on this case, I was going to ask, it's pretty obvious, but what is the diagnosis for this patient? Anybody? I see your name, Sarah, so I'm going to pick on you because I know you. What do you think? What diagnosis would you say this patient has? I can't read the chat. No? Anybody? Yeah, got it. Okay, sorry, my chat pops up a little. Alcohol use disorder, correct. This is pretty straightforward. So it's alcohol use disorder, and you probably all know it, but I just wanted to go over the criteria with you guys. Basically, if you're having a problematic pattern of alcohol use and with significant impairment or distress with at least 2 of the following and the below in the 12-month period, we can label it as alcohol use disorder, diagnose it. So I gave an example of that guy earlier because he sort of met all of the criteria as I go over with you. He's drinking larger amounts. He's having desires to cut back, but is unsuccessful. He's spending a lot of time in activities to obtain alcohol, and he's having a lot of urge to use. We're kind of, deducing from this point, but he has not been able to fulfill his roles. He's having social and interpersonal difficulties at home. And he is having a lot of falls, which would count as physically hazardous. And he's using despite knowing that it's causing a lot of physical and psychological problems. And he is already, you know, demonstrating tolerance to alcohol because he's drinking a fifth every day and he's still going to work, and he's having withdrawal symptoms whenever he's coming off of it. So he meets basically most of the criteria. And in the DSM, and we can specify into mild alcohol use disorder, moderate, or severe based on how many criteria that they meet. And most of the patients who come through our hospital would be severe. And the other diagnosis that I give to my patients when they come is alcohol intoxication based on how much they've been drinking and if it pops up in their alcohol level when they come in admission, and also alcohol withdrawals, whether they have with or without perceptual disturbances. All right. So, okay, you guys have to answer again. What other things, if you were the intake coordinator or like part of the team admitting him, what else would you like to know about him that might be important in knowing in an admission? Anything? Anything is fine. I'll hear a few things and then I can proceed with the next slide. Is Ashley Dash? All right, social support stuff. Yeah, that's very important because I think at discharge, that's what we really want to know, because depending on their support system, it's gonna tell us where they can go. If they're homeless, yeah, they can't go anywhere. But what else would you like to know? How about something, a past treatment? Yep. Yeah. So that definitely, and current treatment. Yeah. What have they tried in the past, especially in terms of rehab options? It helps. Oh, and it kind of ties into what I'm going for next. Past treatment will kind of tell you if they've been treated before, what sort of withdrawal symptoms they have had, because the types of withdrawal symptoms they have had is going to help us determine where the severity of their alcohol use. So, and also current treatment, yes. What else have they been on in the past for alcohol use or any other psychiatric meds, really, because those are all helpful things to know. All right. So past treatment, I think, is kind of similar to what I think I always ask Crystal, who's our intake coordinator. I ask her, these are a few things that I really want to know from our patients. And one of the things is actually how much they've been drinking and when their last drink was. And I'll kind of explain why soon. So I want to briefly touch on the importance of sort of knowing what the blood alcohol level means when a patient comes in, or the blood alcohol content. Their blood alcohol level, or BAL or BAC, is influenced a lot by the patient's weight and how fast they can metabolize the alcohol and how fast they've been drinking. Usually in most states, the legal limit of alcohol is 0.08%. And I think some states are even 0.05. And our body usually metabolizes about 0.015 to 0.020% each hour, which is also, I'm going to say the numbers because this is what we use in the hospital a lot, but 15 to 20 milligrams per deciliter is when each hour you'll notice it decreasing by that much. And that's important because then we can kind of calculate like how much longer is it going to take them to be a little bit more sober, or how much longer is it going to be, or we can kind of guesstimate how much they've been drinking based on their alcohol level. And a lot of times they minimize their drinking. Here is a chart. Left side is female, right side is male. It shows based on their weight and also the number of drinks, the level of intoxication. So the green is, possibly drunk. So if it goes beyond 0.08 is when it's legally intoxicated. So basically, yeah, the more you drink, and if you're a lighter body weight, yeah, just having 2 drinks, it might get you legally intoxicated. But if you're, a little bit more heavier, then it depends. You can take more drinks, things like that. So, and then it says in the bottom, you can subtract 0.05 each hour after drinking. And that helps us because we want to know how sober they are and how much I can believe like what they're saying. Sometimes during interviews, if they're too intoxicated, I don't really listen too carefully. There we go. And here it kind of shows, based on the different levels of alcohol in your body, the types of presentation that they may come in. So anywhere from 0.11 to 0.15% is when you're feeling drunk. You're feeling a little bit more like depressed, not like mentally, but like physically a little bit depressed in your nervous system. And you're having gross motor impairment. Your judgment is severely impaired. And by 0.16 to 0.19, you're very drunk. You're having nausea, dizziness, motor impairment, blurred vision. And then 0.20, 0.24, you're very confused. You don't know where you are. You're vomiting everywhere. You can't really walk. And then sometimes this is when patients say, you know, if they've had blackouts before, that's because they're too drunk, not necessarily because they're having withdrawal seizures or things like that. 0.25 to 30 is stupor. So really everything is impaired. This is when you can really get into accidents. All of your sensory functions are kind of not there anymore. And then 0.31% and up, you can be in a coma. However, a lot of our patients, when they do present to the hospital, they're actually like over 0.31%. So it's like 300 milligram per deciliter, even in the 400s, upper 400s. But they're able to talk fine and they're able to function even when they're so intoxicated, when actually they should be in a coma. And I wanted to kind of explain to you how that's possible for chronic drinkers. This is sort of a graph that kind of shows, not a graph, but an image that, well, I'm trying to show to you guys how they can be so functional when they're drinking so much every day. So in the first picture, this is for, you know, people who don't drink that much. This is kind of a balance. This is the GABA system, and we call it like the braking system in your central nervous system. So, and this is glutamate, and this is like the excitatory neurotransmitters in your body. So when somebody drinks, like if you and I were drinking and we drink a lot, then the alcohol is going to be pushing on this side. So basically, it's breaking your body. So everything kind of slows, you're more relaxed, and then you're not as, I guess, aware of the situation because your excitatory system is not working as well. It's kind of going off balance, right? However, if you're a chronic drinker and alcohol is constantly in your body wants to function, right? So all of the brake receptors, the GABA receptors in your body are going to produce, they're going to be less receptors in your brain, basically. So what happens is, even if there is a lot of alcohol, the body somehow manages to have less brake receptors activated. So you can still function normally without feeling overly sedated or something or depressed. And at the same time, what that does to make up for that, our body creates a lot more excitatory kind of neurotransmitters, right? So now the glutamate is upregulated over here. So even if you're drinking heavily, now there's a new homeostasis. So that's why they're able to function just like people who are not drinking every day. And that's why there are high functioning alcoholics, right? So when you're in withdrawal, now the alcohol's out of your system. So all of a sudden the brake system is lifting up, right? And now you're feeling very excited, not excited, but like all of your excitatory neurotransmitters are firing. And that's why you get the high blood pressure and all of the other symptoms that I'm going to talk to you about next when you're withdrawing from alcohol. I hope that makes sense. All right, back to the case. So now we've admitted them. They're in the hospital. So like we talked to them the next day and I asked the nurses what's going on. And per nursing collateral, it says patient has been sweating profusely, complains of tremors and shakes, and has had bouts of nausea. The vital signs show elevated blood pressure of 150/90, pulse of 110, and they're afebrile. And patient is looking very distressed, just sick during interview, and the room is very dark. Oh, okay. So based on day one, I just wanted to kind of go over the different withdrawal symptoms that patient can be going through. You probably all know, but these are the mild alcohol withdrawal symptoms. You may have felt this, you know, in your life too. Just feeling very anxious. You have some shakes. You're not sleeping well. You're getting headaches. If you had a heavy night of drinking, right? And then now you're not drinking anymore, and stomach upsets. And moderate alcohol withdrawal symptoms include all of the above, plus you're sweating a lot, your blood pressure is going up, you're breathing really fast, your heart's beating really fast. Sometimes you can be even a little confused and a little mild fever too, okay? And I wanted to show you the timeline of when the withdrawal symptoms happen. If you look at the graph here, it kind of shows from 0 hours and 6 hours and 12 hours since their last drink. That's why it's important to know when they had their last drink is, because we can kind of suspect, okay, what's happening? How far are they in their withdrawal symptom timeline? So anywhere from 6 to 36 hours since their last drink, which is anywhere from day 1 to day 2 of their hospital admissions, they may have mild withdrawal symptoms. In addition, they can also be having seizures anywhere from 6 to 48 hours span. You can notice some withdrawal seizures here. If you see there's a peak there. And these seizures will happen more if their nutritional status is not doing very well too, and they have low magnesium and things like that. So we make sure we supplement for that. Anywhere from 12 to 48 hours is when we can expect some patients to have hallucinations. Usually they're visual. And from anywhere from 48 to 96 hours since their last drink, they can have something called delirium tremens. And I'll talk a little bit more about that later, but basically it's when you're having, on top of hallucinations, you're having hallucinations plus disorientation, and you're having vital sign changes, and you're having some mild fever. You can get very agitated, and you can be sweating profusely. All of those above combined, we call DTs. A lot of times patients use that term very loosely, but not everything is considered to be DTs, okay? But they tend to appear a lot later during the treatment timeline. So if you look, that's anywhere from day 2 to day 4. So usually I keep my patients anywhere from 3 days to 5 days, depending on how they're progressing in their withdrawal. And sometimes they stay close to a week as well, depending on how well they're progressing. But that's like a safe enough timeline to say if something were to have happened, it should have happened within that week. So, okay. So we're going to go over day 2 and day 3 of the hospitalization. So day 2, patient thinks the medicine that we've been giving him has been helpful, but he continues to have tremors and he still feels not very good. Day 3, now he doesn't know where he is, and all of a sudden he's talking to somebody in the room when no one is present. He doesn't know why he's in the hospital now, but he initially knew, but all of a sudden he doesn't. And now he has a difficult time remaining focused during the interview and is tangential. Now he's having a fever. Now his blood pressure is even higher and his heart rate is going up. What do you think is going on? Anybody? You can type it too if you don't want to speak up. What is happening to this patient right now? Out of the withdrawal symptoms that we talked about, what do you think he's undergoing? No, maybe I didn't explain properly. Oh, that's okay. I'll go over it again. Basically, he's going through delirium tremens right now, which is a very severe state of alcohol withdrawal symptoms. So if you look up again, so he is disoriented, his vital signs are unstable, and he's confused, he's hallucinating, all of the above. That combined will look like a DT. Okay, sometimes you can have tactile hallucinations too, and sometimes that can include seizures. And when the DTs are very severe, then sometimes we actually transfer them to the ICU when we can't control it in a regular medical floor. And then they start treating them with very heavy gun medicines. And I'll go over the medicines that we use when they're in there. Wanted to briefly touch on what measurement tools that we use when they're in the hospital. We call it the CIWA or the SUS. Our hospital uses the SUS, but the ICU uses the CIWA, so it's a mix. It stands for Clinical Institute Withdrawal Assessment for Alcohol or Severity of Ethanol Withdrawal Scale. So this is a kind of a picture of the SEWA scale. I don't know if you can see closely, but basically it's asking a lot of questions about, I can't see, do you feel sick to your stomach? Have you vomited? And then based on their answer, like no nausea, no vomiting is a 0, and then constant nausea, frequent heaves and vomiting, that's a 7, and it asks about different withdrawal symptoms like tremors, sweats, anxiety, agitation. Some they ask and some they observe. But a lot of times questions like, are you having hallucinations? And then they will say yes or no. And depending on that, the scores can vary. So the pros and cons about having a measurement tool when they're hospitalized is, one, the good parts are, depending on the score, we can tell if the patient is progressing from the alcohol detox or not. And it's a standardized way of measuring withdrawal symptoms. So even if there were different nurses, we can still kind of get a standardized way. And their scores sometimes helps us to titrate the medicines. The bad thing about the measurement tools is that it's very subjective, and some patients may abuse the system and they may report symptoms that are not really there. Like they may say they're hearing things and seeing things, but not really appear to be looking at internal stimuli. And then they would score a very high score, and then they would receive more benzodiazepines. And sometimes they like the benzodiazepines and they tend to abuse them. So if they're constantly using benzos and their vital signs and everything is not supporting the scores, then we can really be suspicious of, okay, they may be abusing the drug. So kind of, we have to watch out for that. All right, and the different medicines that we use during hospitalization, I want to touch on them briefly. There's a class of benzodiazepines, which include lorazepam or Ativan, diazepam or Valium, or chlordiazepoxide or Librium. These medications are the mainstay of alcohol withdrawals because they're acting on the receptors that the alcohol may have been acting on, and this is going to help them kind of ease their withdrawal symptoms for the most part. It comes in IM form, IV form. For a few of those, our mainstay usually is lorazepam or diazepam, and depending on their clinical status, we pick one or the other. Some are better for young people, some are better for old people, things like that. Some with liver issues, we can't use certain ones. So we watch for all of that when starting it. We also give them sort of analgesics and antiemetics as needed, like ibuprofen, Zofran, Docusate, like for constipation. We make sure that there's having some nutritional supplementation as well, like folate, multivitamins, and thiamine, because a lot of our alcoholic patients, they don't eat very well. They've kind of messed up their gut, so not everything is absorbing properly. And having these deficient vitamins can lead to additional clinical problems that I won't talk about here, but that can lead to more severe consequences that's rooted in alcohol. Other medications that are important are anxiolytics. Basically, the patients withdrawing from alcohol can be very anxious. So we try and balance it out with medications like gabapentin or SSRIs or even sleep aids, because the sleep infrastructure in a chronic drinker is very, very messed up. So we oftentimes they want something to help with sleep as well, and we try and avoid them using more benzodiazepines than they should by offering these other medicines to balance out their anxiety. Okay, so now day 4. Patient is doing a lot better now, oriented with lesser use of benzodiazepines, and that's a sign of progress, and this is what usually happens. They use less medicine as time goes. However, patient is becoming very anxious about discharge and worries that he will go back to drinking as soon as he leaves the hospital. And this happens with most of our patients as they're clearing from the withdrawal symptoms and from their alcohol intoxication. Their anxiety kind of peaks up and they start using a lot more benzos because they're worried about leaving. They think they're going to relapse. They don't have a place to go. Things like that. So let me see, what I get? Oh, okay. So at this point is kind of when we educate them again about the importance of, maintaining sobriety. And I don't know if anybody saw the next slide, but what can we offer to them at this time, do you think, when they're kind of, progressing? And Ashley might know the answer. I don't know if our Ashley is here. It might be in the other Ashley, but or Sarah, I don't know. What can we offer to our patients at this point when they're a little bit more sober, a little bit less withdrawing? Any thoughts? And this is probably your realm now. What do we offer for our alcohol patients when they've detoxed, I guess? Anybody think of anything? Type it in. Yeah, hydroxyzine is great, and resources for inpatient treatment. Correct. Hydroxyzine helps a lot with our anxiety. Yeah, we actually use that a lot too. I didn't mention it earlier, but that's great. And resources for inpatient treatment. So that is definitely, that's going to be one of my slides at the end. I'm looking for one more answer. What other somebody must have went over this with you guys in the past, because I think I saw it in Dr. Fink's lectures, Dr. Hilton's lectures. I know they've talked about it before. What I'm looking for a specific type of medicine. What would we like to offer them? It doesn't have to be the exact name of the medicine, but what class of medicine? Yeah, Dr. Fink. Naltrexone. So I want to go over medications that can help with alcohol use disorder. Oops, sorry. FDA approved medicines for alcohol use disorder. So this is what I wanted to kind of let everybody know about, because if patients talk about it, it'd be good to know about these meds. So naltrexone is our opioid antagonist that we use a lot. It's most widely used these days to help with alcohol use disorder. How it works is it reduces the cravings for drinking, and it helps patients drink less when they are actually in the state of drinking. And studies have shown that they have better efficacy in reducing cravings compared to acamprosate. Acamprosate is another FDA-approved medicines for alcohol use disorder. I kind of, when I explain it to my patients, I say acamprosate is a medicine that might help maintain the period of abstinence. How it works is it modulates NMDA receptor transmission and can have indirect effects on GABA receptor transmission. So overall, it will help sometimes with withdrawal symptom itself when it started soon after detox, and sometimes it helps maintain abstinence. But studies have shown mixed reviews about acamprosate. So naltrexone is usually what we go with while we're in the hospital. They can come in pill form, and they can also come in injectable form where you can take it just once a month. So people who are not on chronic opioids, that would be a great medicine that they can use, or they don't have severe liver issues. Naltrexone is usually what works really well. The side effects of this medicine, it tends to go away within a few days, but it's usually just stomach upsets and feeling a little dizzy. So we recommend this to all of our patients during hospitalization, given its efficacy. So I always ask them right around day 3, day 4, even as soon as they get there, because it's going to help them maintain their sobriety. The other one is called disulfiram. That's been around for a while, I think, but I don't use this as much. It's an alcohol deterrent. How it works is it builds acetaldehyde levels by blocking the enzymes that kind of break down alcohol. So basically, it's when you're taking this medicine and you start drinking, or even like a hand sanitizer that have some alcohol in, that's going to create hangover effects immediately, and you're going to feel very sick. This I prefer not to put my patients on this because one, they're going to get really sick. It can create more problems. And a lot of times, especially our current times, alcohol, the hand sanitizers are everywhere. So it's not the best choice of medicine. Other medicines that we tend to offer our patients for alcohol use, it can be Topamax, gabapentin, baclofen, or nalmefene. The last one I've never tried it on. But these are all different medicines that we can offer to our patients that are not FDA approved per se, but they have been, there were efficacy shown in studies where they are used as off-label, especially for patients who cannot tolerate medications that we talked about on top. Okay, day 5. Patient was able to tolerate the naltrexone with some mild nausea. Patient states he cannot return home to his wife because she said he needs to get this fixed before he returns. He would like to know what other options he can pursue to maintain sobriety. So I think Sarah answered this question before. Basically, this is when we need to start talking about the inpatient rehab options or other things. So, okay, that's on my next slide, but I want to go over evidence-based medicine. So patients receiving naltrexone plus medical management, in the studies, the definition of medical management was they had like 9 sessions where, doctors and nurses are there, and then pills were given to them, and they provide education, risk factors, discussions, encouragement, MI, all of the above. In the context of patients receiving naltrexone, medical management, and CBI, so the behavioral interventions, medical management, all of those combined tend to produce longer periods of abstinence compared to those people who didn't receive any medicine or any cognitive behavioral intervention. I think that the combination of things is a little odd, but basically, no combination produced better efficacy than naltrexone or CBI alone in the presence of medical management. I think what the study is, so this is saying that we should always offer some sort of medication like naltrexone, and also offer some behavioral intervention for our patients to succeed in maintaining sobriety. So back to what we were talking about. So we always try and organize inpatient rehab while patients are in our hospital, because that's going to be the best chance for them to maintain longer periods of sobriety. And the longer they are able to maintain sobriety, the lesser chance of them relapsing. So in our hospital, we have like a resources sheet, and there are a lot of different places that they can go to. You probably know better than me, but even patients with senior care or no insurance, it's a little bit more limited, but there are options out there. Transportation is covered, and then the whole stay is covered. And sometimes you have to work for it, but there are options out there. So our more motivated patients, we really push them to call inpatient rehab or the different programs before they leave the hospital, because oftentimes they will pick them up from the hospital unit and take them straight there. And that's really the best case scenario. If, for example, they can't do inpatient rehab because, they have a kid at home, or they can't stop working, et cetera, or things like that, then we can offer other outpatient options. Another sort of inpatient/residential treatment would be a sober living home. And a lot of patients coming from sober living homes tend to go back to it because there's a good community of people in similar situations. It seems like they do offer therapy sessions and support groups within the sober living house. And you have to work to live there sometimes too. So a lot of times patients prefer sober living homes if they've done inpatient rehab before as well. Another option would be like intensive outpatient programs. I know Dr. Fink, Dr. Hilton, Dr. Brand, they're piloting that IOP right now at OU side. And usually what that consists of would be just group therapy sessions, and then medication management with psychiatry, and also support groups offered. I'm sure Dr. Fink will have more to say about that, but those programs are also offered. There's one near Edmond and Arcadia Trails, and that seems to help a lot of people too. This is good for patients who still want to stay home but want something a little higher level of care. And there are, I think, programs that kind of offer a little bit evening options too. But there are also outpatient support groups. You're probably familiar, the AA's 12-step and a lot of other support groups in the community. At least we offer those. We give, I think we have like a typed up resource that we give them when they leave so that they can pursue it on their own. And while they're in the hospital, we try and conduct some motivational interviewing. But a lot of times pursuing that in outpatient setting or inpatient rehab or wherever they go, usually it's embedded in wherever they go for follow-up care. Cognitive behavioral therapy is important, and you guys probably know better than me, and also combined behavioral interventions. So those are all the things that we provide our patients. I think that was my last slide, but I really zipped through. Any questions at this point for me? I am done.
So Dr. Hahn, I don't know
Yeah.
if you want to keep sharing, but what do you think about, like subacute or subclinical withdrawals that occur, in maybe 2-3 weeks? Do you ever encounter that, or do you address that, or do you think that's not the case, or what?
2-3 weeks after their alcohol intake?
Yeah, after they've stopped, after you withdrawn them, and then they have some subclinical withdrawals, kind of a rebound withdrawal a couple of weeks after. Do you ever see that, or have you encountered that?
When they haven't been drinking alcohol at all? Since they left, like since they completed detox, they haven't drank anything at all. I haven't personally. It's kind of well, a lot of times when I do discharge patients, it's when their, vitals have looked a lot stable. But a lot of times they're still very anxious. So in terms of that, I think anxiety can definitely persist because, like I talked about briefly, like the receptors are probably still not quite in balance yet. So I do think, yeah, withdrawals can linger out till later. And at that point, really, I think the anxiety, I'm not sure if it would be coming directly because of alcohol or from now that newly regained sobriety. But I haven't really seen like seizures or hallucinations popping out of nowhere after 2-3 weeks since their last drink, if they've been properly treated. But yeah, if you find someone like that, let me know. I'd be curious to find out more.
Okay.
Yeah. Did anybody come to you like that?
Well, a long time ago, there was a discussion in literature about subclinical withdrawals, which would be just kind of, 2 or 3 weeks, there'd be increase in blood pressure and irritability and those kind of things. And there's a lot of discussion about, that was one of the times that people actually needed to be engaged in treatment because they would tend to, what they call these kind of subclinical or subacute kind of withdrawals, just kind of very mild kind of withdrawals.
I mean,
2 or 3 weeks.
that I can totally see that happening. The irritability and anger, those definitely I think can happen. And I think that's why it's so important for them to have some sort of follow-up care and inpatient rehab, because if that were to happen and there is a group of supporting, staff or, other, patients, then it'd be a lot safer for them and for easier for them to get help too. So, yeah. Anybody else? Anything else related? It doesn't have to be alcohol. We see sometimes opioid patients, we just discharge one. But yeah, if there's anything else I can answer, I'd love to. But if not, thank you for having me. Hope it was helpful. I don't know.
I think it was very helpful. Anybody else? Frida, Cynthia, anybody got another question for Dr. Hahn before we start the weekend? How about benzo withdrawals?
Oh yeah, we see those too. Definitely dangerous population. They tend to have, I think, a lot more severe withdrawal symptoms. And that's definitely like their vitals I've seen go up real hard. A lot more cautious in that population. But yeah, we treat those too. I think Dr. Chuka is routing somebody my way for that. So I do a lot of the benzo, like not detox, but I taper patients off very slowly in outpatient setting. Especially if they're older, but yeah.
All right, anyone else? This is your chance. Okay, Dr. Hahn, we appreciate it. We'll start the weekend a few minutes early. Appreciate your talk. It's very good, very informative. Thanks a lot.
Oh, thank you. Of course. I hope it's helpful in your, patient population. Thank you for having me.
Okay, thank you. All right, bye-bye.
Bye.
Have a good weekend.
You too.